早晨，大家好。我係 Jenny，Dr. Genevieve Fung。咁就大家可能識唔識我呢？我係喺以前係 USage 嘅 Neonatal ICU 度做嘢嘅。咁最近呢2個月呢，就轉咗過去 Prince of Wales Hospital 嘅中大嗰度做research 同埋做 NICU。咁就希望將來同大家多啲見面啦。好，咁我今日呢就會講 Sedation Course 嘅 Lesson 4啦。咁我會轉翻做英文講嘅。咁我哋開始啦喎。So today we come to the 4th and final lesson in the sedation course. In the previous lessons, we talked about different aspects of sedation, including the initial assessments and preparations, sedation procedures and medications, as well as monitoring. In this lecture, we will explore the post-sedation, post-procedure recovery phase, which occurs after the procedure is completed. This is a part where many complications can potentially occur. So good monitoring and preparations are very important here so that the patient can be discharged home safely. In the post-sedation phase, we should be watching out for any adverse events and emergencies as the child wakes up from sedation and make sure that we react promptly. We also need to ensure that there's good documentation so that if any problems occur, we can always go back and review the situation. On a positive note, good documentation is very important for audits when we want to improve our practice or when we want to do studies in the future. I will show you some templates for documentation later on. And after documentation, we'll talk about adverse events and emergencies and also about transport. So in the post-sedation phase, we can categorize it into the recovery phase and also the discharge phase. For the recovery phase, continuous monitoring after procedure is very important. We want to make sure that the following criteria are met in the patient. This includes that the patient has a patent airway, the patient has protective airway and breathing reflexes, the patient is hemodynamically stable, and also easily aroused. And for the recovery phase, ideally, monitoring should be continued near the procedural site. However, in many departments, this is not possible because of lack of space, and the patient may need to be transferred back to the ward. If so, we must ensure that there's continuous monitoring during the transport. This is even so for short distances. If a patient develops a complication during transfer, we must be able to recognize and respond immediately. And after recovery, we go on to the discharge phase in the post-sedation area. So here are some discharge criteria that must be met before the patient can safely go home. First of all, the child must be stable with a good cardiovascular function. Airway must be patent. The child must be alert with intact protective reflexes. And the child should be able to talk or sit up unaided if age appropriate. And for very young or handicapped child who cannot do what we expect, who cannot achieve the milestones we expect, we would expect them at least to go back to the pre-sedation level of responses and be functioning at a level as normal as possible. And we must also ensure that the hydration status is satisfactory, especially if children were kept NPO before the procedure. They must be accompanied by a parent or responsible adult who is not the driver to take the child home. I think all of us understand the rationale behind this. If the parent needs to tend to the child during the car trip home, he or she cannot be driving at the same time. And however, we put it here because some parents may not be aware of this, so we need to remind them. Another important thing is to provide information to parents so that they know what to look out for, which is the warning signs, and how to seek medical help. Some hospitals may have a discharge pamphlet for parents to read, and the pediatric nurse or doctor should go through the important points with them to make sure that they understand. So we go on to the next part, the documentation part of the sedation. So documentation, some important points to note is that for documentation, we should include the following points. For the pre-sedation preparation, we should have a pre-sedation medical evaluation, the fasting status, and the consent. For the sedation record, it should be a time-based flow sheet where we have a record of the dosage, the route, the time of the drugs, the patient's response, the vital signs, any oxygen that we're giving or any ventilation support that we are giving, or any interventions and the patient's response, and any untoward reactions and their resolution. And before discharge, we want to make sure that the patient is ready for discharge, and we want to know where the patient is going to. Is he going to home or going to other places? And ideally also, we should have a standard sedation form that can facilitate documentation. So in 2020, a working group was set up in HA to review the guidelines on pediatric sedation. One of the tasks of this group was to review the documentation sheets, and this is the revised version. As I said, good documentation is very important, especially if we want to review the case in the future. And it's also important when we want to look back and see whether we have done things correctly or whether there's any room for improvement. So let us look closely at this. This is a template for reference. Different hospitals may like to develop their own sedation records. So for our template, page 1 involves mainly the pre-procedural period. Relevant information to document includes the patient's medical and sedation history. Are there any medical conditions which poses risk for sedation? Did the child have any past history of failed sedation and why? And we need to know in order to plan better. Other relevant data are the physical examination. Are there any abnormalities there that requires attention? Is there any infection risk or need for isolation? And after that, we need to assess the sedation risk and formulate the sedation plan, whether we want to give oral, IV, or intranasal. Fasting time also needs to be confirmed. And the next section documents the patient's condition and vital signs before the procedure, which serves as a baseline for monitoring. And these boxes show the sign-in and the time-out points. The page 2 here is a sedation phase. This is a sedation checklist on airway equipment and medications to reverse sedation, which is seen in box 1. And the box is the sedation medical records, and with detailed documentation of the drugs used. And the final part is the observation chart. And page 3 is for post-sedation. First, there's a sign-out box at the top to document the child's vital signs and conditions. And using the pre-procedure sign-in box, we can quickly check and see whether the baseline of the child has been reached. And the checklist for discharge also ensures that the patient has fulfilled the discharge criteria. Finally, this is the adverse events box. Adverse events are rare but important and should be documented carefully. Many times when we go back to review the even major events, we find that the documentation is not as good as we had expected. The box provides a checklist for basic important items to document, like the etiology, clinical features, management, outcome, and classification, whether it's an AIRS or sentinel event. So after going through the documentation, let us have a look at the adverse events and emergencies. A lot of these events, emergencies, are not common. However, they may be life-threatening. So let us have a close look at those. So who are the patients who are at risk for complications? So here's a list here. ASA physical status 3 or 4, patients with history of airway obstruction, difficult intubation, loud snoring, or obstructive sleep apnea or central apnea. Patients with poorly controlled asthma, patients with obesity, premature or preterm infants, especially those with preconception age less than 60 weeks, those with active pulmonary, cardiovascular, GI or neurological problems, those with seizures, uncontrolled, those with uncontrolled gastroesophageal refluxes, children who are having procedures that require deep sedations, and sedation in patients with a full stomach. Hopefully that won't happen. And children with severe developmental delay, and children with history of failed sedation or sedation problems in the past. And so what adverse events can happen during or after the sedation period? All of these are actually quite important ones. Those include upper airway obstruction, laryngospasm, apnea and respiratory depression, aspiration, hemodynamic instability, and anaphylaxis. And let us go through them one by one. So let us look at the upper airway obstruction and laryngospasm first. So for upper airway obstruction, most commonly it can occur due to loss of pharyngeal muscle tone or due to obstructive sleep apnea when the child falls asleep, and laryngospasm. And loss of pharyngeal muscle tone, for normal children, airway patency is maintained by contraction of the pharyngeal muscles. However, if the child is breathing deeply, then it will create a negative inspiratory pressure. And if the airway is also collapsible due to loss of muscle tone, it will lead to partial airway obstruction. So this diagram is a graphic illustration of what happens in upper airway obstruction. The diagram on the left, this one, shows a child with normal pharyngeal muscle tone. The muscle tone maintains airway patency during both inspiration and expiration. And the diagram on the right, this one, shows a child with loss of pharyngeal muscle tone. The airway is more collapsible and collapses inwards during inspiration due to negative pressure, and therefore the airway becomes narrow and obstructed, as you see here. So for obstructive sleep apnea, it's mainly a sleep-disordered breathing. And contrary to what most people think, children with obstructive sleep apnea are not all obese. You may have some thin children or some normal weight children who also have obstructive sleep apnea. So beware of that. Children with craniofacial abnormalities have a higher risk of sleep apnea. And children with history of snoring, difficulty in breathing during sleep, apnea during sleep, sweating during sleep, restless sleep, or daytime somnolence are also indicative or also suggestive of sleep apnea. And a lot of children may be undiagnosed at the time of procedure, so be beware of that in the history too. And signs of upper airway obstruction include if the child has partial obstruction, you may hear stridor when he's under sedation. The child may be snoring at night or may have noisy breathing. Or worse still, there may be paradoxical chest movement. And if the child then desaturates and develops hypoxemia, it is a late sign of upper airway obstruction, and we need to intervene. So how do we manage upper airway obstruction? Simple measures include reposition of the head and neck to align or open the airway to maintain patency. From our PALS and our basic life support course, we have learned that the chin lift and the jaw thrust is helpful for this. This relatively simple maneuver of repositioning can maintain airway patency in many cases. Further measures of managing upper airway obstruction include giving oxygen, suctioning if excessive secretions are present, and if the condition does not improve, then we can proceed to CPAP or oral nasal pharyngeal airway. Finally, for more support, the child may need laryngeal mask airway or even endotracheal intubation. So another life-threatening, very important complication that can occur after sedation, during sedation, is laryngospasm. Laryngospasm can occur due to reflex responses to light anesthesia and also laryngeal stimulation. And it causes involuntary and sustained spastic closure of the vocal cords. So as you can imagine, if the vocal cords are closed completely, then the upper airway is completely obstructed and the patient cannot breathe. So it's a potentially life-threatening condition. However, it can be partial or complete upper airway obstruction. And the child may present with signs of upper airway obstruction, and early signs may include coughing, or the patient may have a characteristic stridorous noise with partial obstruction. So how do we treat laryngospasm? First-line measures include opening and repositioning airway with jaw thrust. Some experts may recommend trying stimulation of the laryngospasm notch, which is performed by bilateral digital pressure on the styloid process behind the posterior ramus of the mandible. However, this maneuver has not been studied in detail, and so there's no good evidence-based evidence for this maneuver. Further actions include CPAP or positive pressure ventilation with bag and mask. We need to assess air movements during these procedures. If airway obstruction persists, then we can try low-dose muscle relaxant like succinylphonium with or without atropine. If, however, the airway obstruction still persists and we are unable to oxygenate the patient, then we may need to administer full-dose muscle relaxant and then intubate the child. So, next complication, apnea and respiratory depression. So we know that most sedative medications will blunt the brainstem receptor response to increase in plasma carbon dioxide, and may also decrease the respiratory rate and death. And these medications include the benzodiazepine groups, the opioid groups, the barbiturates, and also chlorohydrate. And at-risk periods are periods immediately after administration of the drug and also after cessation of the painful procedural stimuli. So one classical example is that after the procedure, the child goes to sleep and then develops respiratory depression or apnea. And we must be watching out for that. And how do we recognize apnea? We can look at the color of the child. Is the child pink or is he cyanosed? We look at the chest wall movement. If the child develops apnea, there will be absence or decreased chest wall movement. We look at the respiratory rate. We look at the pulse oximetry to look at the saturation. And we can do untitled capnography to look at the CO2. So respiratory rate, as we said, varies with age. So this is a reference range for respiratory rate from infants to adolescents. It's important to use reference ranges according to age. For example, if we have a teenager with respiratory rate of 12 per minute, it is within normal range. However, if a 2-month-old has a respiratory rate of 12 per minute, it is too slow and it's not normal, and we may need to observe carefully and intervene. And so for treatment, if the child has apnea or hyperventilation, we can have some verbal encouragement for the child to breathe, or we can stimulate the child to help him to breathe. Other measures include airway support, the chin lift, jaw thrust, as we talked about just now. We can give oxygen supplement. However, if all these measures are not useful, then the child may need positive pressure ventilation with bag and mask device. And also note that if the child is on medications for sedation, we can try to slow down and stop the medication. And in other cases, we may try to reverse the medication's effect. For example, if the child is on opioid like morphine and fentanyl, we can try naloxone to reverse the effects. If the child is on benzodiazepine, we can use flumazenil. One thing of note is that the duration of action of the reversal medications is usually shorter than the sedation medication. So we have to be cautious and continue to monitor the child. For example, if we administer naloxone for a child who is on fentanyl, he may wake up after the naloxone injection. However, he may then go back to sleep again and develop apnea again later on when the effect of the naloxone wears off. So we must continue to monitor him carefully. So another complication that we may expect with sedation is aspiration. And aspiration means that if the child develops vomiting, he may aspirate the gastric contents into the lungs, and that causes an inflammatory response. This may lead to, in severe cases, acute lung injury or ARDS. And the risk is greater in patients with brief episodes of apnea or significant respiratory depression because esophageal tone and protective airway reflexes may be absent during these periods. And how do we recognize aspiration? The child may cough, may wheeze, there may be shortness of breath and distress. When we listen, there may be decreased breath sounds on one side or bilaterally. The child may then develop tachypnea, tachycardia, cyanosis, and desaturation. And if we do suctioning, we may find gastric contents in the oropharynx. And the child, in severe cases, the child may develop reflex laryngospasm and bronchospasm. And when we do a chest X-ray, we may find evidence of aspiration pneumonia changes. So how do we treat aspiration? We can turn the patient head down and turn the patient to the side. We try to suction and clear the airway. We can give oxygen supplement. In more severe cases, we can give CPAP. In even more severe cases, the patient may need endotracheal intubation for airway protection, ventilation, and tracheal suctioning. And in extreme cases, the child may need bronchoscopy with tracheobronchial toilet. And because aspiration may cause infection in the lungs or pneumonia, then bronchodilator and antibiotics may be required. So we then go on to the next item on the list, which is hemodynamic instability. This is also a life-threatening consequence or complication of sedation. So hemodynamic instability may include hypotension, hypertension, tachycardia, bradycardia, and in the worst case scenario, cardiac arrest. So this is, as in the respiratory rate assessment, heart rate and blood pressure varies with age. This table from the 2020 PALS course shows that the heart rate and BP of children at different age group is different. So please remember to refer to the table for reference range of both the systolic and diastolic BP. So, for example, taking a 4-year-old child, the lower limit of systolic blood pressure should be 70 plus 2 times age, so which means 70 plus 2 times 4, which means 78. And so we can refer to this table when we're looking at children of different ages as a rough guide. So hypertension, for children with hypertension, we should try to delineate the cause and treat accordingly. So questions to ask ourselves would be, is there a pre-existing medical condition that the child would have low blood pressure? Is the hydration status satisfactory? Is the child dehydrated or shocked? Or are there any cardiovascular abnormality that may predispose to hypertension, like myocardial dysfunction or poor contractility? And next thing, a very important thing to look at is the sedation medications. Most sedation medications can cause hypertension or decrease in blood pressure. For example, the morphine or fentanyl type. However, one drug of note is a ketamine. Ketamine, if it is used, its sympathomimetic effects may result in increase in blood pressure and heart rate. However, it also has a direct vasodilatory effects, which may result in hypertension in critically ill patients with depleted catecholamine stores. So, if the child is on ketamine, it may result in either high BP or low BP. So, be aware of that. So how do we treat hypertension? We can position the patient and to improve the venous return. We can give the patient some intravenous fluid or fluid boluses. In patients with quite refractory hypertension, we may need to consider inotropes or vasoconstrictor therapy. And if the patient is on medication that will cause hypertension, then we can consider decreasing or stopping the medication. And so the opposite of hypertension is hypertension. Some children may develop hypertension in the peri-procedure or during the procedure period. And so when does that occur? For children who have pre-existing hypertension, they may get very anxious during the procedure and may then develop peri-procedure hypertension. And pain can cause hypertension, as well as anxiety, agitation, carbon dioxide retention, hypoxemia. As we talked about, drugs like ketamine can also increase the blood pressure. Children with raised intracranial pressure, children with excitement, shivering can also increase the blood pressure. Simple discomfort like bowel distension or urinary retention can also result in hypertension in children. So we need to identify the cause and treat accordingly. And we will have to make sure that the blood pressure is normal before the child can be discharged home. And other problems of the cardiovascular system would be sinus tachycardia, could be due to pain, agitation, hypercapnia, hypovolemia, shivering, bleeding, fever, or drug. And we need to examine the child carefully to know what is the actual cause for the sinus tachycardia. Sinus bradycardia, which means the heart rate is too slow, could be due to a number of causes like abnormality of the heart pacemaker system, surgical injury to the heart pacemaker system, cardiomyopathy, hypoxia, acidosis, hypotension, hypothermia, drugs, bowel distension, increased intracranial pressure, oculocardiac reflex. And we also need to examine the child carefully to know which one is the cause. So for bradycardia, we have to be very careful because tissue hypoxia can lead to symptomatic bradycardia in children. And for the child becoming bradycardic, it may be an ominous sign that he is impending cardiac arrest, especially in smaller infants and children. And if that is associated with hypertension or poor tissue perfusion, then we need to be extra careful. So for bradycardia, we need to treat the underlying cause, remove the stimulation if related. We have to ensure adequate oxygenation and ventilation. We may need to apply drugs to improve the heart rate. And if, despite good oxygenation and ventilation, the heart rate is below 60 with signs of poor perfusion, then we have to begin CPR. So the worst complication that can occur is cardiac arrest. Sometimes this occurs when warning signs of deterioration are not recognized. For example, if a child develops apnea post-sedation and is not treated promptly, he may then deteriorate to cardiac arrest. And we hope to prevent this event by careful assessment and monitoring so that the pediatrics team looking after the child can be alerted to changes or deteriorations in the cardiovascular status and treat proactively. And this is the algorithm for cardiac arrest management. And this algorithm should be available in the ward so that whenever there's a need for CPR, we can refer to that quickly. And finally, adverse events and emergencies in sedation would be anaphylaxis. Anaphylaxis is an antigen-specific IgE-mediated event, including that involves 2 or more body systems. And signs and symptoms may include anxiety or agitation, nausea, vomiting, urticaria, angioedema, respiratory distress with stridor or wheezing, hypotension, tachycardia, palpitations, and arrhythmia. And so treatment for angioedema or treatment for anaphylaxis, we have to stop the allergen, or usually it's a kind of medication. We have to give the patient oxygen. Fluid bolus is like a normal saline bolus or lactate rana may be given. Treatment for severe reactions would be intramuscular adrenaline, or very, very severe cases may consider IV adrenaline. Antihistamine, salbutamol, and corticosteroid. One thing of note is that if we are administering intramuscular adrenaline, it's 1 in 1,000 adrenaline rather than the 1 in 10,000 that we use when we are doing neonatal resuscitation or when we are doing CPR. So finally, last but not least, we want to talk about transport. So during transport, there should be continuous monitoring of vital signs by medical staff, including color, heart rate, blood pressure, respiratory rate, SpO2, plus or minus end-tidal CO2. We must ensure stable airway, breathing, and circulation before departing. And resuscitation equipment to bring along would include at least a manual resuscitative bag, valve or mask, airway device, suction, oxygen, and medications. Most departments would have a checklist of transport equipment before departing. And colleagues experienced with sedation management and emergency life support should escort the child should anything occur during transport. So, before transport, the team needs to anticipate potential problems and prepare accordingly. Procedures may be difficult during transport, so be aware of that. Unexpected problems usually result from poor planning and preparation, so we need to plan carefully. Nowadays, in addition to intra-hospital transport, there is an increasing number of inter-hospital transport. For example, transport to and from Hong Kong Children's Hospital for cardiac surgery, etc. So, no matter whether the journey is long or short, please make sure that the whole team is well prepared and well organized before starting on your transport journey. So this is the end of lesson 4. I hope you have enjoyed learning about different aspects of sedation, and we hope that you have enjoyed these lectures as well. And after the lectures, you'll be going on to workshop for sedation, and we hope that you can participate actively in those, and because those all the scenarios in the workshops are very relevant to your usual practice. So bye bye.